The topic of presentation is approach to spinal cord diseases. So here we'll be discussing about various topics of extramedullary, intramedullary, extradural, intradural, and also where the congenital causes or genetic causes of spinal cord lesions, how they present and all. So we go on a case-based scenario. A 20-year-old male presented with a complaint of progressive weakness of left hand muscles, which went on to involve the forearm muscles with wasting, and MRI C-spine was normal. So you can see there is a progressive wasting of left hand muscles. So they are not telling about anything about whether the flexors are involved or extensors are involved. So they are telling entire left hand muscles are there is a weakness. So generally, so since there is a weakness, always single muscle group is like a single limb is involved. Always look for the peripheral nerve causes, but generally each nerve supplies a different kind of, like certain nerves supply flexors, certain nerves supply extensors. Here they are not telling flexors or extensors company, they are telling entire hand muscles are involved. So it's unlikely because hand muscles are supplied by radial nerve, ulnar nerve and median nerve. They are all combined to supply the hand muscles. So no single group muscles are involved, no adduction palsy, no abduction. They are not specific muscle palsy. If you can tell that, maybe then you can localize it to a peripheral nerve. Since it's unlikely to involve three nerves at the same time, so it's unlikely that entire hand muscle is supplied by three different. It's unlikely the pathology is lying at three different nerves. We go a little proximal. So whether the palsy is at the level of plexus and where the brachial plexus are involved, where they can involve the like where you can explain the pathology. But generally, brachial plexus injury is highly unlikely unless you have a traumatic incident. But since the brachial plexus injury if happened, it involves the entire muscle group of upper limb, left upper limb. It doesn't involve only intrinsic head. It is unlikely to involve only single muscle group of hand muscles and all. And it is also very painful. Since there is no history of trauma model, brachial plexus injury is unlikely here. So then you go ahead to the cord level. So at cord level, so when you can localize it to the hand muscles, all intrinsic muscles of hands are mostly supplied by C8T1. So all extensors, flexors, almost all hand muscles supplied by C8T1. So you can localize at the cord level to C8T1. So C8T1 are the root value which supplies most of the intrinsic muscles of hand. So if you involve the forearm also, maybe C7 you can take into consideration. C7, C8T1 are the most of the cord levels which can supply the most of the muscles which are involved in this case. So why we didn't take the peripheral nerve? Because most of the peripheral nerve supplies certain flexors or certain extensors. This is not such case where and all muscles are involved. Both flexors, extensors and abductors all are involved, which can't be explained by single peripheral nerve. So that's why we went to a spinal cord level. So spinal cord pathology might be a possibility, but MRI C-spine came out to be normal. So there is a progressive muscle weakness, there is wasting definitely, and also involvement progressive weakness is there involving the forearm also, it is progressing. So MRI C-spine is normal. What is the possibility in this case? So if you look at the diagram of this, there is a wasting of the muscles and there is also there is a oblique atrophy where there is single brachioradialis is paired, all others are in this oblique muscle is brachioradialis which is paired and all other muscles are there. You can see the wasting for all other muscles. This is classically seen in the case of Hirayama disease. So Hirayama disease is where there is a posterior dural sac enlargement is there which can compress the cord, so it causes cord atrophy. So this might be a case of Hirayama disease where MRI C-spine when done in the normal position it might be normal. So you need to do a flexion, neck flexion and do an MRI, then you will find the posterior dural sac enlargement, so which is compressing on the cord you will find. So this might be a case of Hirayama disease where you need to do MRI in neck flexion. So that will explain why there is a wasting muscles of intrinsic muscles of hand muscles and also forearm. So this is mostly seen in the second to fourth decade. So the treatment you advise for this patient is mostly conservative, where you advise them to not to flex his neck and also you advise the cervical collar so to avoid the flexion. So generally they'll recover unless there is significant cord atrophy. They'll mostly recover. If it is a short duration, there is no significant cord, they mostly will recover. But most of them will be can be managed conservatively. So this is an interesting case of Hirayama disease, which is most commonly seen in South Asians, where you find hand muscle wasting, progressive weakness is there, and maybe no MRI might be normal in normal position. But when you get a flexion MRI, flexion neck MRI, you'll find Hirayama disease. So this is the case. A 6-month-old brought to the OPD with complaints of unable to hold her neck and roll on bed or sit. So she's a 6-month-old. She was not able to hold her neck or roll on bed or sit. So you can by this you can tell there is a weakness of truncal muscles and neck muscles. So since it's a 6-month-old, you should always look for the genetic causes. So genetic causes are always possibility when you are having some being flaccid, like you can't like when you hold her neck, she falls off. Like there's a floppy neck is there. So always look for the genetic cause. Most common cause in this case is spinomuscular atrophy. So this is due to the mutation in survival motor neuron gene. There are SMN1, SMN2 gene, both are there. SM1 is the one which is mostly responsible for the entire SMN gene. SMN2 partly accounts for it. So based on the how much genetic SMN affected, how much amount of SMN is being generated, so that it depends on the presentation, at what age it is presenting. Also it varies on the amount, how much amount of survival motor neuron gene is affected. So this is a 6-month-old. This might be because of spinomuscular atrophy, which is very common in India. So there are various therapy. Nusinersen is there, many drugs are available and trials, so you can try them. So this is survival motor. 0 is absent, completely absent gene. It presents at birth. Severe hypotonia, they'll die with respiratory insufficiency. SMA1 can present on 2 weeks to 6 months, where mostly die by ventilation by 2 weeks. They can't unable to sit or roll. So SMN2, 6 months to 8 months, where the proximal weakness, unable to walk independently. They can sit sometimes. Those can survive till adulthood. Based on the how much amount of SMN deletion is there, so the more SMN4 has less deletion or less significant affection on the SMN. Here completely absent. SMN gene is completely absent, so they won't have any survival. So SMA3 less than 3 years, more than 3 years. Based on which age it is involved, their motor milestone will be available. Their lifespan also depends. Generally, SMA3 and SMA4 can have a normal lifespan. So this is the different kinds of spinal muscular. We'll again discuss it later, but I'm telling you this is the case of SMS. A 24-year-old male presented with complaints of weakness of left hand associated with wasting and also have dysphagia and dysarthria. On examination, you noticed fasciculation of tongue and muzzle. EMG showed delayed recruitment. So a 24-year-old male presented with complaints of weakness of left hand. Similar to the previous case, there is definite weakness of left hand associated with wasting and also have dysphagia. Here bulbar symptoms are also present. So on examination, you introduce fasciculation. So definitely fasciculations are suggestive of LMN palsy. There is LMN palsy. So there is left hand wasting. So there is a limb wasting. There is a fasciculation of tongue. There is dysphagia and dysarthria. So ENMG showed delayed recruitment. So what is the possibilities case? So 24-year-old, definitely there is wasting is there. So there is a bulbar level weakness is there. There is limb weakness is there. So you can't localize it to a cord at one point. You need to localize it to the cranial nerves also. If there is a cranial nerves and brainstem also. So two different locations are there. So 24-year-old, there is significant wasting is there. So ENMG was done and you notice fasciculation. So the dysphagia and dysarthria. So you ask for the what? First thing you need to ask for in this patient is only LMN palsy is there. So wasting and all wasting fasciculation are all suggestive of LMN palsy. When you look at dysphagia and dysarthria, you need to ask what kind of dysarthria, what kind of dysphagia. So if there is any nasal regurgitation is there, if there is spastic dysarthria or flaccid dysarthria is there. So that will tell you whether both LMN is involved or LMN human both are combined involved. Sometimes when you ask for dysphagia, they'll choke or they'll have spastic dysarthria, like they'll stress on words and speak in some patti matladu. So that kind of spastic dysarthria might be there. So that might be suggested, that might be the only human feature that might be there. So generally if both human and LMN are both are involved, so that is the classical symptomatology called amyotrophic lateral sclerosis, where you find both LMN commonly is called spinomuscular atrophy, whereas the human component is lateral sclerosis. Both can be combined called amyotrophic lateral sclerosis. So that is a motor neuron disease. So this might be a case of motor neuron juvenile ALS. This is a case of juvenile ALS. Generally juvenile ALS has a good prognosis, better prognosis, because it's slowly evolving. It's slowly evolving. But bulbar ALS is very bad prognostic again. Here bulbar component is that might be a bad prognostic, but generally juvenile ALS is a good, like it has a better prognosis when compared to later onset ALS. So here classical LMN symptoms are present, but if you ask on the symptomatology of dysphagia and dysarthria, if you find anything else, upper motor neuron involvement is there, then definitely ALS is possible. Even only LMN is also only spinomuscular atrophy component might also be a presentation in ALS. So it can be LMN variant, it can be human variant, it can be combined variant. So ALS can have different presentations, where only LMN variant is there, that is spinomuscular atrophy is there, only flaccidity, wasting, weakness is there. Only human variant where you have spasticity, where increased tone is there, increased reflexes are there, that might be a possibility. So only human, both combined here. If you check the reflex of this patient, maybe reflexes might be exaggerated. That might be a combination of human and LMN palsy together. So here presentation can be n number of presentations. So ALS might be a possibility. So ALS can present in many different ways. So pure LMN can be a possibility, pure UMN can be a possibility, and LMN plus a UMN can be combined a possibility. Here pure LMN or LMN plus UMN is a possibility in this case. And also it can present in different also, only limb is involved or only bulbar involved. So based on that, here only both limb and bulbar variant is there, that is also a possibility. So generally bulbar is a bad prognostic factor, and also juvenile is a good prognostic factor. This might be ALS. So, but what is the requirement of what is the significance of ENMG showing delayed recruitment? So, what happens in ALS is this nerves whatever are there they die. So, if there is no nerve supply to the muscle, there won't be any recruitment of muscle. So, when you do ENMG, so there won't be recruitment of muscle. So that is suggestive there is significant nerve damage. So that is one of the things you said, that is a picket fence matter, that is suggestive of that is one of the thing that is suggestive of ALS, that is motor neuron disease, where the delayed recruitment is there. So early recruitment is generally seen in the case of muscle disorders where nerve supply is all good, but since the muscle has no significant potential, it has to recruit more muscles to generate the potential. So early recruitment and early recruitment is generally seen in the case of muscle disorders, where delayed recruitment is seen in the case of nerve damage. So since the muscle is damaged, nerve supply is all good. So in order to gain the same amount of potential, it starts recruiting more and more muscle fibers. So early recruitment is seen in the case of muscle disorders, where delayed recruitment, because nerves are not there at all. So since nerves are at all not there, so there is no recruitment at all. So that is why delayed recruitment is in the case of ALS. So this is a 40-year-old male, known case of alcoholic, presented to OPD with complaints of wash basin attacks and tingling and numbness of foot. On examination, you notice there is an increase in tone in the limbs, lower limbs, and deep tendon reflex are exaggerated. So absent plantar reflex and absent joint and position sensor there. So he is an alcoholic. So wash basin attacks are generally there are different kinds of ataxia. There is sensory ataxia, there is cerebellar ataxia mainly. So and also you need have otic system and also eye system vision for the maintenance of balance. So generally what happens in wash basin ataxia, your vision is completely lost when you're washing your face. So and also so most of your balance depends upon your sensory fibers. So that is why when there is a sensory ataxia, you will find wash basin attacks, because most of your body is balance depends upon your sensory fibers. That is why sensory ataxia, wash basin attacks are sometimes when you're navigating through dark narrow passages where your vision is completely compromised. So that is where the sensory fibers play main role in maintaining your balance. So that is why classical symptoms of sensory ataxia is where you find unable to navigate through dark passages or wash basin attacks. So that is suggestive sensory ataxia. And tingling and numbness of foot. So that is also posterior column symptoms. And there is increased tone in the lower limb, and deep tendon reflexes are also exaggerated. So that is suggestive there is some spastic upper motor neuron component of motor system is involved. And absent plantars, absent joint positions are just a posterior column. So this is an alcoholic case. There is, you can see the posterior column is there, lateral column involving the motor fibers is there. So this is a classically a case of posterior lateral column is involved. So this might be case of subacute combined degeneration of spinal cord, which is commonly seen in B12 deficiency. So due to the alcoholism or any other cause, B12 deficiency is a possibility. So B12 deficiency causing classically posterior lateral syndrome, where the posterior column is involved, both the and lateral cord involving the, you are finding the motor symptoms where you human kind of symptoms are there. So how do you what are the other causes of posterolateral syndrome? Generally, posterolateral syndrome is involved in the HIV. There is one more cause called HTLV1 virus, and is also involved in the case of copper toxicity or nitric oxide ingestion. Copper deficiency or nitric oxide ingestion. So these are the other possibilities where you find posterolateral syndrome, where you classically find the symptomatology of combined posterior column symptoms and the motor symptoms. So that is classically a posterolateral syndrome, where you find B12 deficiency, copper deficiency, nitric oxide ingestion, or HIV, HTLV1 virus is a possibility. So that is one different differential. But so this is a B12 deficiency case. You are classically finding there is posterior column involvement, there is increased deep tendon reflex and all. So what if there are absent? There is no increased tone in this case. So the absent deep tendon reflex are there. So reflex are absent. There is no increased spasticity. What is the possibility in this case? So the other possibility is Friedreich's ataxia, but the age is also a confounding factor. Age is also a problem in this. Generally, Friedreich's ataxia generally present less than 25 years. Pure posterior column symptoms will be there. They'll have absent reflexes. They will have like peripheral neuropathy. The associated cardiac condition, any hypertrophic cardiomyopathy or diabetes will be there. So that is a genetic condition, that is autosomal recessive condition, generally present less than 25 years. Pure posterior column symptoms will be there, and also some peripheral neuropathy, motor weakness will be there. Absent reflexes will be there. And also you will have other cardiac and diabetic condition. That is a classical presentation of Friedreich's ataxia, generally present less than 25 years. So So both the B12 deficiency, generally they'll ask, how do you differentiate in B12 deficiency, subacute combined degeneration, and Friedreich's ataxia? Because both involve posterior columns. The classical difference is the reflexes. Reflexes are generally normal in the case of, normal, little exaggerate in the case of B12 deficiency. Generally they're absent in the case of Friedreich's ataxia. That is one differentiation. This might be a case of B12 deficiency due to subacute combined degeneration, where posterolateral columns are generally involved. The other differential will be copper deficiency, nitric oxide ingestion, or HIV or HTLV1 virus. You supplement with B12. So B12 can cause dementia also. Sometimes a B12 deficiency can cause dementia, and depression also is depression. Cognitive symptoms is also present in the case of B12 deficiency. A 70-year-old female presented to OPD with complaint of excessive laughing during the conversation, and he's choking while eating the food and stressing words while speaking. On examination, you found wasting of muscles of upper limb and fasciculation. So this is again a case of motor neuron disease where you are finding both UMR and LMN. So human findings are generally human findings, human fibers. Human findings, you can find the stressing while one, this is spastic dysarthria or choking, and also excessive laughing. Generally, emotional liability is something suggests a pseudobulbar. Pseudobulbar is human variant of, like for peripheral nose, how it is there. For cranial nose, the human variant is pseudobulbar. Bulbar is LMN, pseudobulbar is human. So emotional liability, where you don't generally laugh, you laugh excessively, that is suggestive of emotional liability. So normally when you are sitting, they starts laughing or they start randomly crying. So that is an emotional liability that is suggests a pseudobulbar variant, pseudobulbar symptomatology. So here both UMN symptoms are there, where emotional liability is there, spastic dysarthria is there, and also wasting of lower limb, LMN palsy. This is classically an ALS symptomatology. What I want to highlight is the emotional liability you are seeing in this case. So that is, if the emotional liability is always suspect pseudobulbar palsy. Why the emotional liability is there in the case of UMN, why it is not there in the LMN palsies, LMN cranial nerve palsies? You read about it and let me know. A 30-year-old female presented to OPD with complaint of postural imbalance. On examination, he has absent position, joint and vibration sense, reflexes are all absent. So what is this case? So she has 30-year-old female. She actually let's say she started having positional imbalance and she was not able, she has ataxic symptoms. She has absent position, joint and vibration symptoms. Let's say they gradually progress till like initially they are till ankle, then progress to knee and all. So only pure posterior column is in the reflexes are also absent. What is this case? So since she is a 30-year-old female, there is no other cardiac or diabetes, mellitus, nothing is there. So this is not a Friedreich's ataxia case, definitely. So what is the possibility in this case? So this might be a case of this is pure posterior column involvement. There is no motor involvement is there. So peripheral nerve is highly unlikely. Since peripheral nerve is involved, sensory, no small fiber is involved. So pure posterior column is there. So if generally posterior columns are supplied by large fibers, if large fibers are involved, so both motor is also supplied by large fibers and both should be involved. So it is unlikely pure peripheral neuropathy. So you go to little proximal. Pure posterior column is a possibility. But generally reflexes is generally spinal cord level. It comes back, reflexes are generally at spinal cord level. Don't go to the posterior column till posterior column. So reflexes will be generally normal. So the problem is at dorsal root ganglia. So dorsal root ganglia is the one which sends the reflexes back. The reflex path is generally at the spinal cord level. So this might be a case of ganglionopathy. So ganglionopathy is a possibility in the case where pure posterior column involvement is there, where reflexes are absent. So that might be a possibility that is seen in the case of Sjogren syndrome or any paraneoplastic syndrome or pyridoxine excess, especially TB patients sometimes excessively take the pyridoxine. So they can have pyridoxine toxicity or thalidomide poisoning. So that is a possibility, and cisplatin also. So the thalidomide, cisplatin, pyridoxine are the few drugs that can cause ganglionopathy. And also mainly we see in Sjogren syndrome. Sjogren syndrome is one of the things which can present with ganglionopathy. I seen in the case of Sjogren, this might be a 30-year-old female with dry eyes and dry mouth. This might be a case of Sjogren syndrome. So that is the thing. The poor posterior column symptoms, no motor symptom, you rule out peripheral neuropathy causes. Since posterior column is pure posterior column involvement is unlike, general reflexes are generally intact in them. So only posterior column symptoms with reflex absent. Think about ganglionopathy. It's slowly length dependent, ascending pattern is there. Ganglionopathy, Sjogren's, paraneoplastic, and drugs like thalidomide, cisplatin, pyridoxine are possibilities. So before going to the spinal condition, you need to understand things. Generally, upper cervical cord, whatever spinal segment is, it corresponds to vertebral level of the same level. But lower cervical cord, whatever spinal segment, let's say C6 spinal segment, your local spinal segment, vertebral level is little higher. That is C5 is the vertebral level. When you go to the upper thoracic level, when you are telling about spinal segment of T5, 2 segments, you need to minus 2 to go to the vertebral level. So that is T3 is the vertebral level. When you go to lower thoracic level, it is generally T6 to median, generally minus 3 is the possibility. So around T10 you will find L1, L2. At T11 you find L3, L4. At T12 you find L5, and generally L1 you find all the sacral fibers. So that is the case. So upper cervical corresponds to the vertebral level, lower cervical generally 1 above, upper thoracic -2, lower thoracic T6 to T9 -3. At T10 you generally find L1. So L1, L2. At T11 you will find L3, L4. At T12 you find generally L5. At S1, L1 you find most of the sacral fibers. That is how you can. I'll again repeat. Upper cervical corresponds to cervical level, lower cervical -1, upper thoracic T1 to T6 -2, T6 to T9 -3, T10 corresponds to L1, L2, T11 corresponds to L3, L4, T12 corresponds to L5, L1 corresponds to sacral fibers. That is how you corresponds to the vertebral level. This is very important. They'll ask you about spinal levels and vertebral levels. A 30-year-old male presented to OPD with complaints of spasticity at lower limb gradually progressing upwards. So whenever a 30-year-old male corresponding only most are generally they have spasticity upper limb, always you look at the lateral corticospinal tract. So only upper limb spasticity is there. Always UMN is a possibility. Corticospinal tract is a possibility. Always you need to localize whether LMN part is involved, UMN part is there. That is makes it easy. Your work a lot easy. So UMN is involved. So spasticity, corticospinal tract is involved. So 30-year-old male progressing weakness is spasticity. Always suspect hereditary spastic paraplegia. HSP is a possibility. Always look at. There might be other cerebellar function, other posterior column functions might be affected, but the main predominant symptom is always spastic paraplegia. Any patient presenting with spastic paraplegia, 30-year-old male, young patient, if there is no history of trauma, nothing is there, always incident and like indolently they are progressing upwards, always suspect hereditary spastic paraplegia. For spasticity, you give baclofen. There is genetic condition, so this might be a kind of hereditary spastic paraplegia. A 32-year-old male present with dull aching pain, progressively increasing back pain, which was radiating to the left lower limb along the posterior lateral aspect of the buttock to foot up for 6 months. So the left lower limb radiating pain is there, as also with back pain is there. This was accompanied by tingling and paresthesia of both lower limbs. 1 month following the illness, he developed asymmetric weakness in the lower limbs involving the proximal and distal muscles. He noticed numbness in the lower half of the body, including perianal area. He also developed the bladder and bowel disturbances with constipation and erectile dysfunction for 1 week before admission. So on a clinical examination, he found had an asymmetric element type of paraparesis with bladder and bowel involvement. So sensory loss is 30 to 40% was present below the L1 dermatome, including perianal region. Spinal tenderness and deformity were absent. So he had normal hemogram, ESR X-ray of lumbosacral joint and chest were normal. So what is this case? So this is one of the case we have seen. 32-year-old female. So she has dull aching pain. She initially has back pain and was radiating to left lower limb. So she has radiating pain. Generally, definitely a root compression, like the root pain is there. Some kind of root compression is going on. It was associated with tingling and paresthesia of lower limbs also. So 1 month she developed asymmetric weakness of lower limbs. So that whatever radicular pain is there. So it is progress into the weakness of both lower limbs involving the proximal and distal limb. Both muscles are involved. So along the root valley there is some kind of compression is there. It is classically look like compressive. Some compressive myelopathy is there. So because there is back pain, there is radiating pain. So there are classical symptoms of there is a level also. There is radiating pain associated with back pain is there, and also there is asymmetrical weakness is there. So that is classically going towards compressive myelopathy. He noticed a numbness in the lower half of the body, including the perianal region. So there is a sensory level also. And so he also developed bowel and bladder disturbances with erectile dysfunction. So later on they involved the bowel and bladder dysfunction. So initially after 8 to 9 months they developed bladder. So the late involvement of bowel and bladder is there. So it is definitely not intramedullary, it is mostly extramedullary. Mostly extramedullary is there because bowel and bladder involvement is there, and since there is a positive point, since there is a back pain, so there is a radiating root pain is there, there is asymmetrical involvement is there, they are all suggestive of extramedullary compressive and also extramedullary. What is extradural intradural will come to know. Okay, on clinical examination he had asymmetric element type of palsy with bowel and bladder involvement, sensory notion, spinal. So spinal tenderness and deformity were absent. So till this point we got to know, since there is a back pain is there is radiating pain is there, asymmetrical weakness is there, bowel and bladder movement involvement is late, so they are all suggestive of extramedullary involvement, and also sacral involvement is also early, that is suggestive of extramedullary involvement. So they are all suggestive of extramedullary involvement. What we need to differentiate is there intradural or extradural. So generally extradural are mostly vertebral causes. So most of them are vertebral causes. So they will have some amount of spinal tenderness or deformity might be present. So their spinal tenderness and deformity is generally absent. So that might be a case of intradural. Whatever intradural is a possibility in this case. So, but here normal hemogram, ESR X-ray of thrombosacral spine and chest X-ray are all normal. So what is the case in this case? So whatever intradural is a possibility in this case. So this might be a case of meningioma, but unexpected this might be a case of TB arachnoiditis, where the TB only involved arachnoid. So there is a TB arachnoiditis which is causing which is intradural. There is enhancement is there. Classical case of TB arachnoiditis is compressing the root. It slowly involved the compression of the cord also, that is causing all these symptoms. So with this one case, you classically can describe what is intramedullary and extramedullary. So intramedullary, early bowel and bladder involvement. Mostly it might be, there is also dissociation, or this sensory dissociation also. Mostly spinothalamic tract is more involvement of the posterior column tracts. So the sensory dissociation is there. Early bowel and bladder involvement is there. And also sacral sparing will be there. Here sacral is involved early. So that is suggested extramedullary. So that is one thing. And also extramedullary, there is extradural, intradural. Extradural is mostly vertebral causes where symmetry is a possibility. Generally intradural is high, mostly extramedullary and mostly asymmetrical. In the extramedullary also, extradural there is a possibility of symmetry because it is vertebral, it can easily involve the both sides. In extramedullary, intradural, mostly they are asymmetrical. They can't involve the both sides. So this might be a case of intradural, since there is no spinal tenderness and deformity is there. Mostly intradural is a possibility because mostly asymmetrical. So this is a case of compressive neuropathy where TB arachnoid is a possibility. So regarding this dull aching pain, no, so there are different kinds of back pain. So back pain can be funicular pain, where you have dull aching kind of pain which is not radiating to anyone, just localized pain which is due to the tract pain, that can be due to the posterior column or spinothalamic tract. Generally, posterior column pain is more of lermatism, where you flex the neck, you will find that electric shock-like sensation. Generally, funicular pain is mostly due to the spinothalamic tract involvement. So, where is a dull aching localizing around that whatever spinal level is there, that is dull aching. It is not radiating to anywhere, it is not changed by position and all. It is a dull aching pain. Whereas the root pain is, it is radiating to somewhere. It is radiating here. In this case, there is a root kind of pain which is radiating to lower limb. So that is a radiating pain. Sometimes most common cause of back pain is due to the muscle pain. The local musculoskeletal system pain is there, which changed with the position. Generally, it changes with the position and exercise. It varies from day to day also. It is more in the night, it is less in the morning. So diurnal variation is there, changes with the position and exercise also. So that is musculoskeletal pain. That is how you differentiate different kinds of back pain also. So this is a case of TB arachnoiditis. A 40-year-old diabetic patient underwent aortic aneurysm surgery, now present with complaints of acute onset flaccid paralysis and urine retention. So what is this case? So generally a 40-year-old diabetic patient he underwent aortic aneurysm surgery. So now present with acute onset flaccid paralysis. Like flaccid paralysis, just say only lower limbs paralysis is there. Below the umbilicus there is paraparalysis and urinary retention is there. Generally below 2.6 you find the autonomic symptoms. You contain postural hypertension and all. So there is a paralysis of both lower limbs is there, acute onset. So any acute onset you should always think of the vascular events. Any acute event, always rule out the vascular events before, and that might be severe stroke or anything. Since both lower limbs and it is unlikely to involve the both anterior cerebral arteries, so it's unlikely. Always look for the both lower limbs. Always look at the spinal level. So this here always there is an anterior spinal artery that might be supplying the anterolateral corticospinal tracts. So this might be a case of spinal infarct. So involved in the anterior spinal artery due to the aortic aneurysm, some kind of a thrombus or atherosclerotic thrombi might be lodged into the spinal artery. So that is causing the anterior spinal artery infarct. That is causing mainly involved in the anterior spinal tracts, that is corticospinal tracts. That is causing the paralysis. Initially it is because of the spinal shock there in the flaccid paralysis. Though maybe in progression might go into the spasticity also. So this might be because of spinal artery. Always any acute event, always look at the spinal. Just because spinal cord is there, that doesn't mean that there is no vascular event there. That is also a possibility. It's very rare, but that is always a possibility, especially after aortic surgeries or something. So most common level is generally thoracic. A 30-year-old female presented with acute onset back pain and developed a weakness of lower limbs. So let's say there is a 30-year-old female presented on lifting weight, she developed sudden onset back pain. So generally disc prolapse. Always gym workers will have disc prolapse in them. So disc prolapse is a possibility where it is causing the compressive myelopathy. It is causing the sudden onset weakness. Generally you don't have sudden onset. They'll have some amount of disc prolapse already present. But acute pain with that might be if they keep on lifting the weight, that disc prolapse will progress and will cause significant weakness, and also have the like at whatever level that is compressive myelopathy, there they'll have LMN palsy. Below that will have UMN lesion. It's like at the level of lesion they'll have decreased reflexes and flaccidity. Below that lesion they'll have spasticity and hyperreflexia and all. So this might be a case of compressive myelopathy, they continue to disc prolapse. So this is the case. So this is the features where we help to differentiate between the different kinds of tumors. Like I told in the female case, and where the tibial retinitis case. So generally asymmetrical. Asymmetrical in that case is an extramedullary possibility. Most of the intramedullary are generally symmetrical. Asymmetrical is for in the extramedullary, sometimes extradural there might be some amount of symmetry, but generally intradural is mostly asymmetrical. So intramedullary is mostly asymmetrical. Generally have local or vertebral pain, or here they will have funicular pain. I'll tell you what is vertebral pain and local pain. So vertebrally they'll have spinal tenderness and all spinal deformity, like in the case of Pott's pain or something where they'll have spinal tenderness in them. And also local pain like musculoskeletal when you'll have change with diurnal variation, and also varies with exercise and all, and also movement of various different posture also. Radicular pain will radiate. Funicular is dull pain which doesn't change with position or anything. It is a dull at the level. There will be some dull pain which doesn't bother with any change in position or any movement or any diurnal variation, or there won't be radiating to anywhere also. Generally, extramedullary generally human signs are generally early. I told you why human signs are early in extramedullary in before video. Watch that video. Generally, element signs are generally early in the case of intramedullary. I told explanation before in the previous. Generally, observe that. Generally, sacral is most commonly involved in the case of extramedullary, like in our previous case where sacral involvement is early. So that is suggested for extramedullary. Generally, sacral is involved late in this case because CTLS is more peripheral. So that is why I explained this in the previous video. Observe that and watch that video. Dissociated central layers where there is spinothalamic tract is involved and posterior column is not involved. Generally, extramedullary involves both tracts, whereas intramedullary generally involves spinothalamic tract more than the posterior column. That is why dissociated sensory loss is there. Autonomic sensory, like bladder symptoms, is late in the case of extramedullary, early in the case of intramedullary. Thank you.